Hello, everyone, and welcome to this audio podcast in this series, the Labtronics series. This is part of the Ballistics edition. It's another RPSG and KDARS collaborative with a Storm Robotics production. And in this audio podcast today, I'm going to be highlighting a little bit about laboratory tests, biomarkers, and investigations. So, chronic kidney disease or CKD. So, historically or traditionally, there are 5 stages of CKD. There has been works that have sort of indicated in and at least in a sort of an overarching sort of way that potentially there could be a CKD stage 6. But before sort of highlighting the sort of premise around that, I'm going to highlight an overview in context of the 5 main CKD stages. So stage 1 is where basically there's renal damage and kidney function or renal function could be absolutely normal, but there could be a raised glomerular filtration rate where it could be more than 90 mils per minute, and basically where under within the normal parameters, the 90 mil per minute in context of renal function and in context of both renal function and glomerular filtration rate would be absolutely normal. However, in CKD stages, in some pathology, in aspects of pathology medicine or laboratory medicine, there is automation, pathology automation in laboratory environments where CKD, even at CKD stage 1, kidney renal function can be deemed as individuals can be deemed as having potentially abnormal function based on even normal parameters because of, for example, particular forms of renal disease where it predisposes the glomerular filtration rate being sort of abnormal in context of screening. Now, in stage 2, this is where there's renal damage or renal insufficiency, and the glomerular filtration rate can be normal, but it can also be raised, and anything between 60 to 89 mils per minute would be absolutely normal in stage 2. However, there are physicians out there, and there are certainly scientists and colleagues out there who would say that stage 2 in the general population would be absolutely normal, would be absolutely normal, but generally along with other for example, for other predisposing issues and factors, stage 2 CKD stage 2 can actually be deemed as abnormal if above this sort of reference range, and also in context again, as mentioned, in regards to CKD stage 1, where there may be other predisposing factors that prompt patients out there to have, for example, CKD stage 2. Now, CKD stage 3 is where there's moderately reduced glomerular filtration rate, and it's anything between 30 to 59 mils per minute. And CKD stage 3, if we look at the general population or look at epidemiology and analyses of population health, generally CKD stage it can fall into the category where the general population would be at potential risk of having CKD stage 3. And one of the main factors around CKD stage 3 is in relating to in regards to screening, and early screening of CKD stage 3 can help individuals and patients to actually fall into the sort of advanced CKD stages, and also in end stage renal disease. Now, the CKD stage 4 would be also known as advanced CKD stage, advanced chronic kidney disease, advanced CKD, or advanced chronic kidney disease. Now, CKD4 is basically where there's severely reduced glomerular filtration rate, and where the filtering components in context of renal anatomy are anything in the range of where the glomerular filtration rate is anything between 15 to 29 mils per minute, and where the functional components, i.e. the nephrons, the filtering components of the kidneys, are more damaged, have been damaged in some way. And then CKD stage 5 is where individuals or patients in the general population, let's say, for example, fall into what is known as end stage renal disease, or ESRD, and wherein the glomerular filtration rate is anything less than 15 mils, where the reference range is less than 15 mils per minute. And there's works by Mohammed and team in recent works where they've highlighted some of the educational aspects surrounding CKD, or chronic kidney disease. Now, and part of the beginning of this slide, I mentioned, for example, there has been works that look at a CKD stage 6. Now, generally, whilst there's no formal consensus around CKD stage 6. There has been some works to indicate that anything that's less than, for example, 10 mils per min would be deemed as stage 6, and wherein, for example, CKD stage 5, as highlighted here, is anything less than 15 mils per min. But however, in stage 6, again, there's no whilst there hasn't been any formal consensus around this. Stage 6 would it would be where, for example, patients would have absolute inability to avoid urine and rid of toxins through the blood, whereas in CKD stage 5, some patients can still micturate, have the sensation of emptying and voiding avoiding urine through their urethras and ureter and through the bladder. However, there is insufficiency. There's insufficiency in that nature. So generally, stage 6, whilst again there's no formal consensus around it, there has been works to indicate that stage 6 could be useful as well. Now, in context of laboratory medicine, one of the main renal biomarkers is a biomarker known as creatinine. Generally, creatinine is a routine biomarker used to determine renal function. And creatinine, from a physiological point of view, is a byproduct of muscle breakdown and excreted by nephrons, which are, as everyone would know, I'm sure, are filtering components of the kidneys. Now, the normal reference range of creatinine is anything between 60 to 120 microliters micromoles per liter. When renal function is evident, the creatinine sort of goes up, increases, and then renal function generally deteriorates. Creatinine levels may be either may be very high or may be very low, depending on, again, the classification and the severity of the form of chronic kidney disease that someone is being diagnosed with. Now, estimated glomerular filtration rate and versus, for example, glomerular filtration rate. Estimated glomerular filtration rate is a clinical standard to determine estimation of renal function. And estimation glomerular filtration rate is also a sort of a calculation that is used to define the staging and classification of chronic kidney disease. And estimated glomerular filtration rate equations are used normally to determine renal function and renal filtration, in conjunction with the biomarkers that are used to determine renal function. As mentioned in the previous slide, I talked about the biomarker creatinine, but there's also a biomarker that can also be used. Another biomarker, for example, cystatin C, which can be also used. However, the evidence in some laboratories versus other laboratories, the evidence for using cystatin C, for example, to replace or use in conjunction with creatinine, for example, have the evidence favors in some works in context of it being used, cystatin C being used with creatinine, and where some works have highlighted that cystatin C can actually be used to replace creatinine, since creatinine has been a long-standing biomarker owing to its from a laboratory pathology perspective, owing to its costs. Whereas cystatin C generally has a bit of a higher cost in context of its in context of how it's used how it can be used in pathology or laboratory medicine. But generally speaking, the evidence around cystatin C, for example, from a consensus perspective, has not wholly informed that cystatin C should be entirely used with creatinine as a traditional biomarker, or to replace creatinine. There are some laboratories, for example, that may use cystatin C, but in context of general population or population health, estimated glomerular filtration rate is still determined through a basic equation or calculation alongside a traditional biomarker to determine renal function, that being creatinine. A little bit about blood urea and nitrogen. So urea is a molecule produced from protein excreted from the kidneys, and the level of urea in the blood arises or is raised in and against chronic kidney disease. And the amount of protein that is consumed can affect the estimated glomerular filtration rate and the glomerular filtration rate as well. And the value can increase. The urea can be raised if individuals, for example, are dehydrated, and erythrocytes in context of where individuals or patients may not be known to have, for example, anemia, let's say, but in a dehydrated state, or where red cells are overworked, for example, generally in context of the BUN, or blood urea nitrogen, in a full blood count, for example, the urea, I'm sorry, the erythrocytes the erythrocytes in context of hemoglobin can be raised if dehydration is evident, and urea can be raised if dehydration is evident, and nitrogen as well. Now, the normal value a normal value the normal value around BUN as a whole, blood urea nitrogen, is anything between 2.5 to 6.6 millimoles per liter, according to healthy or general population. Again, urea is accumulated, can accumulate in blood in blood through chronic kidney disease, and it is not an accurate. Is on its own. Urea is not an accurate investigation for renal function, but it is useful and is helpful when in together with other investigations that are linked with the full blood count. Now, potassium is an electrolyte, and generally comes from fruit, vegetables, and nuts as well. And potassium rises in patients and people with chronic kidney disease, or a form of chronic kidney disease. Potassium levels can also rise in where some individuals are prescribed certain medications as well, and it can be dangerous when the kidneys do not function adequately, and thus potassium can be raised in when patients are predisposed to particular conditions, and high potassium levels can be treated by patients being prescribed certain drugs to balance out, for example, potassium and calcium. If the potassium level is high and renal function is low, then what will normally happen, or may happen, is where a patient may have to be worked up to have a form of renal replacement therapy, for example, dialysis, where hemodialysis if necessary. Now, the normal range in context of the potassium is anything between 3.5, 3.6 to about 5 millimoles per liter. In relating to another important electrolyte is sodium. So sodium generally comes from salt, which I'm sure everyone is aware. It generally increases when the kidneys do not function so well, and increased sodium can cause high blood pressure, swelling, or edema-like symptoms, and fluid in and around the lungs, in and around the respiratory system. And diuretic medication, or diuretic medication, can increase the sodium output in some contexts. However, most patients are informed, and most patients with a form of renal disease, and those who are in the general population, generally are informed to eat less salt, have less salt in food, and for example, and and if required, for example, for a short time, then some patients in the general population and renal patients, or those in falling into particular chronic kidney disease categories, may, for example, be prescribed diuretics. The normal value in the healthy population is anything between 135 to 145 millimoles per liter generally. And when there is renal insufficiency, generally the sodium as an electrolyte versus potassium and calcium, for example, rarely changes. Generally, in regards to the electrolytes, sodium and calcium are the most important electrolytes, and sodium is important, but on its own, a bit like urea, on its own, in some contexts, it's next to useless to determine, for example, renal function from, but also on its own, it's next to useless. For example, when looking at or identifying whether someone is suspect or high risk for a form of renal disease. Anemia in CKD is also a well-known complication, and associated with can be associated with poor health-related quality of life, and also quality of life generally, and increase in morbidity and mortality. The mechanism of anemia in CKD are generally multifactorial, and can include, for example, for example, patients who may be prescribed certain medications, for example, erythropoietin. Erythropoietin is generally in normal renal function, erythropoietin is produced from the kidneys to help stimulate red cell production. Now, from anemia in a CKD perspective, what happens is that when hemoglobin is evidently reduced in patients, and has been determined, patients in CKD are prescribed or can be prescribed, for example, erythropoietin, which is injected subcutaneously, and it generally helps stimulate red cells for patients in CKD, and it generally helps helps raise the hemoglobin, and iron and erythropoietin. There is some evidence to indicate that erythropoietin also helps raise iron and nutritional deficiencies, where, for example, where patients who have where there's evidence, where there's fatigue or lethargy, patients who are prescribed erythropoietin, for example, along with iron, if there's evidence that iron is reduced, then generally speaking, what happens is that a patient can, or individuals may, alongside that, may not feel, for example, the sensation of wanting to, for example, eat or drink, as in normal hemostasis. And what would happen is that erythropoietin is prescribed to help stimulate the red cells, which then in turn also help stimulate the drive or the sensation to want to for example eat and drink, as in the case would be the normal population. Now, various pro-inflammatory mediators commonly elevated in chronic kidney disease may also affect the erythropoiesis, or the pathway in context of how red cells are stimulated. And where red cells are stimulated, the general terminology is known as erythropoiesis. And so in this as well, uremic induced inhibitors of erythropoiesis have an effect, and shortened erythrocyte survival, and disordered iron hemostasis has also been documented and evidenced as well. Anemia in CKD is also a well-known complication, and associated with can be associated with poor health-related quality of life, and also quality of life generally, and increase in morbidity and mortality. The mechanism of anemia in CKD are generally multifactorial and can include, for example, for example, patients who may be prescribed certain medications. For example, erythropoietin. Erythropoietin is generally in normal renal function, erythropoietin is produced from the kidneys to help stimulate red cell production. Now, from anemia in a CKD perspective, what happens is that when hemoglobin is evidently reduced in patients, and has been determined, patients in CKD are prescribed, or can be prescribed, for example, erythropoietin, which is injected subcutaneously, and it generally helps stimulate red cells for patients in CKD, and it generally helps helps raise the hemoglobin. And iron and erythropoietin. There is some evidence to indicate that erythropoietin also helps raise iron and nutritional deficiencies, where, for example, where patients where there's evidence, where there's fatigue or lethargy, patients who are prescribed erythropoietin, for example, along with iron, if there's evidence that iron is reduced, then generally speaking, what happens is that a patient can, or individuals may, alongside that, may not feel for example, feel the sensation of wanting to, for example, eat or drink, as in normal hemostasis. and what would happen is that erythropoietin is prescribed to help stimulate the red cells, which then in turn also also help stimulate the drive or the sensation to want to for example eat and drink, as in the case would be the normal population. Now, various pro-inflammatory mediators commonly elevated in chronic kidney disease may also affect the erythropoiesis, or the pathway in context of how red cells are stimulated. And where red cells are stimulated, the general terminology is known as erythropoiesis. And so in this as well, uremic induced inhibitors of erythropoiesis have an effect, and shortened erythrocyte survival and disordered iron hemostasis has also been documented and evidenced as well. Anemia increases progressively again as estimated glomerular filtration rate declines. Anemia is also associated again with poor outcomes, including high mortality in patients with ESRD, end-stage renal disease, and in those with and in those individuals or patients with non-dialysis dependent CKD. There's works by Coyne and team in 2017 and talk a little bit about this. And the prevalence of anemia is high in patients again with who are on different forms of renal replacement therapy, and those who are suspect or high risk, and those who are on non-dialysis CKD, and where there's an increase increase in CKD progression, and also where, for example, and where, for example, there is evidence between, for example, where patients are approximately around 42 where renal function is around 42%, wherein in regards to CKD classification and severity, 42% is around CKD stage 3, and where between CKD stage 3 at 42% and increasing up to 76% in CKD stage 5. It has been there's evidence to prescribe erythropoietin in patients that fall in that particular fall within that particular remit. And non-dialysis CKD and patients on dialysis can have disordered iron metabolism due to increases in hepcidin, which is known to be one of the regulators of iron absorption and release from cells. And there's works again by Coyne and team who highlighted this in 2017. In context of renal replacement therapy, and specifically hemodialysis, hemodialysis is a form of renal replacement therapy, whereby there is a process of removal of toxins and waste from the blood, and treatment does not completely perform all the functions of what renal anatomy does. Hemodialysis is prompted when an individual reaches end-stage renal disease, and wherein estimated glomerular filtration rate it falls below 15 mils per min. And the procedure is generally, apart from removal of toxins and waste from the blood, the procedure also actually is responsible for the development of oxidative stress as well. Yes, so another form of renal replacement therapy is peritoneal dialysis, and peritoneal dialysis involves using a peritoneal membrane as a filter inside the abdomen. A catheter is inserted into the peritoneal cavity, and it's recommended. Historically, it's been recommended for younger patients, but is used in the adult population as well, and owing to its flexibility, and it can be performed in center or pretty can be it can be performed in center but also anywhere else, and the patient must be capable to perform peritoneal dialysis, or have someone with them, and peritonitis, unfortunately, is one of the most common infections with those who undergo this form of renal replacement therapy. So, in relating to iron deficiencies, I've talked a little bit about, for example, hemoglobin, anemia, hemoglobin, and red cells, etc. In relating to that, there's iron deficiency. Iron deficiency is unfortunately quite common in those in the renal replacement therapy sort of population, generally speaking. Iron is generally is essential for many important biological reactions, including oxygen transportation, cellular respiration, and DNA synthesis. Systemic iron balance is maintained by regulating dietary iron absorption and iron release from storage sites in the liver. In chronic kidney disease patients, however, there can be loss in iron, and for example, an example of this might be, for example, might be where a patient may be on a form of renal replacement therapy, and there's evidence the evidence there's some evidence to inform that estimated that there can be a loss of iron of anything between 1 and 3 grams of iron per hemodialysis session for those individuals who are on a form of renal replacement therapy in context of hemodialysis, due to for example, bleeding, whether that be chronic or acute, from uremia associated platelet dysfunction, and also where there may be frequent phlebotomy, and for example, where there can be blood trapping in the dialysis or dialyzers attached to dialysis equipment. This is the final slide as part of this audio podcast. Just a few acknowledgements here, and to colleagues who had been involved in sort of co-developing this sort of slide set. Olczakowska and Christine, who represent the RPSG and also KDARS. Thank you again for tuning in on this audio podcast in this series, the Labtronic series. Thank you.